Bassi. I'm a postdoc researcher at Johns Hopkins University, and here I will be presenting about annotations and how can we efficiently train tumor segmentation models. So this work is based on the paper, this presentation is about the paper Learning Segmentation for Radiology Reports, which won the Mikai Best Paper Award runner-up. So we are very excited to share this work with you. So what's the problem we're dealing with here? The problem is that for tumor segmentation, we have very few tumor segmentation masks, especially in public data sets. So if you look for kidney, pancreas, and liver tumors, you can find about 1,000 masks for each in the largest public data sets. However, if you look for other tumor types in CT scans, like uterus, prostate, esophagus, spleen, bladder, and gallbladder, you can find no public masks for these types of tumors. And this is a big problem if you want to train a tumor segmentation model. So we look for another type of annotation, which are the reports, the radiology reports. And unlike masks, which are only created for research, basically, reports are written every day by radiologists. So you can find public data sets, like Merlin from Stanford, that has 16,000 CT scans with reports. Reports about tumors, which cover all these tumor types, unlike the masks. And one single hospital, like UCSF here, can offer us about 100,000 CT scans and reports. So you can see in this plot that the difference between reports and masks is massive. So another important thing is the value of reports. Normally in computer vision, people train with images and labels or captions. But these captions, like the captions in social media, often they are not really describing what you see in the image. So they are not really useful. But in medical images, it's different because the report describes with details what you see in the image. And they give quantitative and spatial details about the tumor. So where the tumor is, how many tumors there are, and what's the size of the tumor. So our question is, how can we use efficiently this information that we have in large scale to train tumor segmentation models? And our proposal is a new training methodology. We call it report supervision, or RSuper. Basically, RSuper can use reports to train tumor segmentation, either entirely substituting masks or in addition, as a complement to masks. So we begin by taking all the reports, and a large language model will read the reports and extract the important tumor information. So where the tumor is, which organ, which part of the organ the tumor is, what's the diameter of the tumors, and how many tumors there are. Then we store all this information, so we run the LLM just once, and then we go to train the segmentation model. When we train the segmentation model, we have new loss functions. These new loss functions teach the segmentation model to segment tumors that match the tumor descriptions in the reports. So for example, if the tumor is the segmented tumor has 1 centimeter, and the report says the tumor should have 2 centimeters, our loss functions will penalize the model to make this tumor larger. So it penalizes the model to have the correct number of tumors, size of tumors, and location of tumors. I will go quickly over the losses. The first one is the volume loss. It's a less strict loss. What it does is it should make the model segment tumors that match the volume of tumor that we can estimate from the report. So the report does not give tumor volumes, but we can estimate them from the tumor diameters. So for each organ with tumor, we estimate what's the total tumor volume inside that organ. Then we also estimate from the segmentation. So we use a pre-saved organ mask, so like total segmentator masks, to find the organ that has tumors, and then inside this organ, we estimate the segmented tumor volume, which is basically like counting voxels and considering the voxel volume. Then we have a loss function that makes the estimated segmented tumor volume match the volume estimated from the reports. This loss function has a special shape, so it has a strong penalization if the model does not find any tumor, but there is a tumor, and it has a tolerance. So if the model predicts a size that's similar to the reports, we don't penalize it, because the tumor diameters are not perfect in the report, so we have a margin there. The second loss function is a little bit more complex, but it makes the model segment tumors that match the diameters, locations, and the number of tumors in the reports. For that, we use a special convolution that we named ball convolution to locate inside the segmentation the most likely location for each tumor mentioned in the reports, according to their diameters and the organ where they are. Then our loss function maximizes the segmentations inside these most probable tumor locations and minimizes the segmentation outside, which are probable false positives. So in the end, we make the tumor match the size and diameters that we have in the report. So now some results. We have compared our model to many alternatives that can also learn from reports in some way. So for example, pre-training with CLIP and then fine-tuning for segmentation. And we see that our model is much more efficient in learning from the reports. So we achieve much higher results. Another very important result, no matter if you have few masks or if you have many masks, if you add reports to your data set, you have much to gain. So here, for example, if we train with 50 pancreatic tumor segmentation masks and we add 2,000 reports, we gain 11% dice in external validation. If you have 350 and you add the 2,000 reports, you gain 8% dice. Even with almost 2,000 kidney tumor masks, if you add 3,000 reports, you gain 4% F1 score. So no matter if you have few or many masks, add reports to your data set and you can get a lot of performance. And this is our last result. So right now we have assembled a very large data set, 117,000 CT scans and reports. And most importantly, this data set focuses on 7 tumor types that you cannot find in public tumor segmentation data sets. So we asked radiologists to create some masks for this data set, about 30 to 200 masks per tumor type. And what we show here is if you train only with the masks, you get the results in gray. But if you train only with the reports, you get the results in yellow. So training with many reports can give you better segmentation than training with few masks. And if you train with both the reports and the masks, you get the results in orange, which are the best results. And if you compare these results to radiologists' performance in the literature, for many tumor types, the AI is already superior because many of these tumors are very hard to detect in CT scans. And we plan to release the first public AI model that can segment all of these tumors.
Excellent, thank you. This abstract is now open for questions from the audience.
Thank you so much and congratulations. I just wonder, can we implement these, like, we have the reports for the different studies and in our institutional data sets. Can we use this for the MRI? And also, let's say we have 10,000 of CT with the reports, and can we use your algorithm? I have seen on the GitHub also, implement easily to label all our data set, like what are the requirements? And also it's 3D, right?
Yes, it's all 3D, great question. So yes, actually in this work, we are using it to help us to label this data set. So we have 100,000 CT scans. We train first only with the reports, and then we create masks, and the radiologists improve the mask. And we have this active learning loop to annotate this data set with the help of this model. So yes, for CT scan, super easy to implement, just go to our GitHub. For MRI, I think there would be no difficulty in implementing this because it's really similar to CT, the spacing, the 3D scheme, the reports are similar. So yes, I think this would be directly applied to MRI.
For multi-label, like let's say there's edema and cysts and the other like non-contrast and contrast regions of the MRI. Also, I'm sure you encounter with the CT with the contrast technique. And have you ever seen the performance on the multi-label dataset?
Here for CT, we do work on multiple contrast phases and we see good performance in all of them. It's better in venous arterial, but we can even have good performance in non-contrast CT. So yes, for other findings, I think as long as you can have a report that gives you the overall size of the disease, then it should be applicable. We can also work now in our latest version with reports that do not give a size at all. But if the reports give the size of the disease, that's very good. Thank you.
Thank you. I had one question. So excellent work. I was just curious, I see on your last slide here that you're using CT reports, but one of the tumor types you picked is prostate cancer. And it seems like prostate cancers are often difficult to see on CT, would prefer MR. So were these cases where the reader thought they could for sure see it and they measured it? Is that okay?
Yes, so many of these cancers, CT is not the main modality to find them. But we see that AI sometimes can see things that humans cannot. So especially for prostate, you see here that the AI performance is much higher than the human performance. So we think this shows that AI can become a technology to make CT an additional opportunistic to detect these cancers. And this, we have access to a very large data set, about 500,000 reports, and then we use LLM to search across these data sets and find these cases where, for example, for prostate tumors, the doctor wrote the size, wrote about the tumor in the reports for the CT scan.
Thank you. That question, if you wouldn't mind going to the microphone, sir, please, so anybody in the virtual audience can hear you. Thank you.
Just one quick follow-up for prostate tumor. As you said, radiologists may be hard to read from CT scans. How can you ensure the volume, the size, and locations are accurate in the prostate reports?
Good question. So for training, we basically go for the information that is in the radiology reports. For testing, now we also have pathology. So we can confirm that these cases have malignant tumors.